explain to you what all these names mean and what are the breakthrough and progresses into this group of epilepsies. So, developmental epilepsy. So this is a group of epilepsies that are presented from the early in life, and they have the association of epilepsy, typically refractory seizures, and some degree of cognitive or developmental delay or both, okay? And for years, we have known that these epilepsies are around, but the initial way that we organize them and classify them were by electroclinical syndromes, okay? Electroclinical syndrome, what this term means is that you have a patient with an epilepsy onset at one age, okay? Any age group, could be during the newborn period, during the infancy, during the toddler years, during the school age years, during adolescent or adulthood, right? Then you put together what kind of seizure this person is having. Is this patient having infantile spasms? Is this patient having a seizure with focal movements, indicating that they are focal seizures? And then you get the neurocognitive status. Does this patient have already a non-developmental delay, or this patient have been developing normal up to this point? And then you score any change in the developmental status. And that information, which is your clinical information, you're gonna put together with what we are gonna find in the EEG, because the EEG is the gold standard testing that we use to put together the electroclinical syndrome, okay? The next thing that I want to tell you is I'm gonna do a historical overview of these electroclinical syndromes, okay? And we start with the first one that was described really in the 1800s by Dr. West, right? But the electroclinical syndrome, okay, for the syndrome of West was completed in 1952 when Gibbs and Gibbs described the EEG portion of that syndrome, okay? So up to them, the physicians knew these patients are infants that started having epileptic spasms, okay? And they were, this was associated with a significant developmental delay or loss of development during the period that the spasms presented. But it was not until 1952 that we knew the third element, which is the hyxarrhythmia, and this is the finding on the EEG, okay? From 1947, there were initial descriptions by Dr. William Lennox and Henry Gastaut, one of my favorite physicians of the past, and they described the association of different seizure types with then in the 50 findings on the EEG to what we know today as the electroclinical syndrome of Lennox-Gastaut, okay? In the 50s also, it was a very important period. Dr. Landau and Dr. Kleffner, they found that there were some children that after being developing relatively well, they start having some seizures, and then they will lose the language, okay? And then they describe the syndrome of Landau-Kleffner or acquired aphasia of childhood. And in the 1970s, Dr. Tassinari also noticed that there were a group of children that presented with seizures and have a change in behavior and learning. And what the common denominator between the patients that Landau-Kleffner and the Tassinari group described later on is that these patients, when the patient falls asleep, there is an activation of a spike and wave during a slow wave sleep, and they denominated this electroclinical syndrome epilepsy with continuous spike waves during a slow wave sleep, okay? In 1970s, Dr. Otahara from Japan described newborns that have early onset myoclonic seizures or tonic seizures, and they have on the EEG a pattern known as suppression burst, and this is the Otahara syndrome as we know it today. In 1978, Dr. Charlotte Dravet, which we still have around with us, described the Dravet syndrome out of a population of patients with Lennox Gastaut, which she observed that these patients were in reality, well, they were lupus Lennox Gastaut, but in reality they were different. They have history of having prolonged seizures in a center of fever of any cause when they were early in life. But one of the things that impressed her was the way that they walk. They certainly have a different gait. Number one, they were able to walk, which was not true for the patient who has Lennox-Gastaut. But they walk with a flexion of the knees that caught her attention. Also, she noticed that the predominant seizure type for this patient was myoclonic seizures and not tonic seizures. So that's how she labeled the syndrome of Dravet. Dravet syndrome was named in her honor. In 1984, Dr. Hervi described, make a precise description of the variation of exarrhythmia going back to the history of Rett syndrome. And in reality, I have to tell you that it was in the 1950s when truly Gibbs and Gibbs and Henry Gastaut also noticed that there were variations in the exarrhythmia pattern in these patients that were having infantile spasms. But I think that the best, more concise description is attributed to Hervi. And in 1995, this is the last of the electroclinic syndromes that affect children. We have the migrating focal epilepsy of infancy, initially described by Dr. Coppola and his group. And these are epilepsies, children who have focal seizures that start from the right or the left side alternating. And they have significant autonomic symptoms as part of the syndrome, okay? So these names that I just described serve as a label, okay, that summarize for other physicians what kind of seizures these patients are having, what is their developmental status, and the age of onset. But this doesn't tell us what caused the problem, what is causing the electroclinical syndrome, okay? So as I mentioned, these are by age group, the electroclinical syndromes with onset in neonate and infancy. We have Otahara syndrome, early myoclonic encephalopathy, epilepsy of infancy with migrating focal seizure, West syndrome, and Dravet syndrome. And then starting later during childhood, we have the Lennox-Gastaut, and we have the continuous spike and wave of slow sleep and the Landau-Kleffner syndrome, okay? This is what we know from the clinical symptoms and the EEG. What we need to know, okay, is how we get to the cause of the problem. Because any of these syndromes can have different causes, right? So these are the steps that we follow once we recognize the electroclinical syndrome. We get an MRI of the brain, okay? And if the MRI is positive, well, we got the information that we need. And we may need to get to genetic testing if the MRI have a lesion that indicate that this patient have a genetic condition. And a common example is tuberous sclerosis. If the MRI is negative, then we should proceed and continue genetic testing, okay? And then we have the choices to do today epilepsy panels. 20 years ago, we didn't have this, we had single genes. So we have basically to go to a roulette until we find a positive one. Today we have panels that group up to 200 genes. So with a single test, you get the answer. And if that test doesn't give you the answer and still your suspicion for genetic is big, then you can go to a whole exome sequence or a whole genome sequencing. And they are arguing in some places that this should be done earlier than we are really doing it, okay? So the development of the genetics has changed the understanding of what causes epilepsy in the population. So in 1975, Hauser and Kurland have this pie chart, and you can see we could not identify the cause of the epilepsy in many patients, and this in the majority of the patients. And these patients were labeled as idiopathic, meaning we do not know, okay? There were other causes like trauma, stroke, tumors, infectious disease, congenital lesions that we were able to diagnose at the time with the rudimentary radiology that we have at the time. Those with very hypoxia, and there were other etiologies, right? This is what we knew then. To this, we have had that now we have a clear understanding of some autoimmune reasons for epilepsy, and this is a field that still needs to have development. And in 1975, we didn't have brain MRIs yet. So when the MRI came, we were able to identify a number of small lesions that were only detectable by MRIs that took a section of that pie away. Yet many of the epilepsies that were considered idiopathic, or we do not know what it caused, it turns out that many of them are caused by single genes, okay? Some of the epilepsies are familiar, but the majority of these are de novo, meaning there is no family history of similar problem in other relatives, okay? When we study the mother and the father, they are also healthy. So this is a mutation that happened in the index individual or patient for the first time, okay? There are epilepsies that have more complicated inheritance, okay? And in which we still suspect that there is some genetic base, but the environment plays a role, okay? And there are also genes that modify or make the patient more susceptible or not to have epilepsy. In this group, we still have some learning to do. But let me show you how the landscape of gene detection has changed what we know about epilepsy. So in the 90s and early year 2000s, it was the era of the channelopathy, because we discovered the SCN1A, which is the most prominent epilepsy in this group, and there were other potassium channelopathies and other sodium channelopathies that were also identified in that era. And that era finished in 2004 when we discovered the CDKL5 gene out of patients who were Rett negative, okay? Then there is a transitional era where the physician said, there is much more that we need to learn here. So around 2008, 2009, there have been an exponential discovery of genes that have been linked to epilepsy. Initially, these patients that have this genetics as the cause of epilepsy were labeled as, this patient has Lennox-Gastaut, this patient has West syndrome, okay? Now we are saying this patient has Lennox-Gastaut due to CDKL5. This patient has Ohtahara syndrome due to KCNQ2, okay? So the etiology is becoming an important feature of the diagnosis, because as a group, the epilepsies that are caused by any of these genetic problems do not respond well to the traditional anti-seizure medications that we have today, okay? Another way to show you how the landscape has changed is the number of descriptions of epilepsy genes that cause epilepsy by years. And we can see that in 1993, there were very few, but in 2017, we have more than 80 genes clearly recognized that cause genetic testing. The reason that I want to mention the importance of genetic testing is 10 years ago, 20 years ago, when we ordered a gene panel, okay, or a gene test, we got a letter from the insurance saying denied because this is research. That was then. The knowledge that we have accumulated about this gene in epilepsy now led us to modify the treatment and to understand which medications probably are going to make this patient worse and which medications should be prioritized because they're going to make the patient better. So no longer we should consider genetic testing as research. This is now part of the clinical information that we need to treat the patient and make the patient better. Okay. Now, what are the most common genes that we see in children, since this is the population that I treat, okay? So we know that 1 in 4 children with epilepsy have epilepsy onset on the age 3 years, okay? And 1 out of 4 children will have a genetic epilepsy caused by a gene. What are the most common? The PPRT2, okay? The SCN1A or Dravet syndrome, the KCNQ2 is unfortunately start very early, which is very devastating epileptic encephalopathy, the SCL2A1, and then we have the CDKL5, PCDH19, and SC6A1 as the following group, TCAP2, okay? The other ones have become more rare, okay? And we need to know about this because the parents have mobilized, the parents of the children who are affected by this gene disorder have mobilized, and now we're getting requests for clinical trials for this population very frequently because everybody agrees that we need to provide better treatment for these patients. And it's not just treatments that provide control of the seizures. We need treatments that also will improve the developmental outcome that for these patients is very detrimental, okay? So one of the terms that we use to describe children who have any of these electroclinical syndromes in the past was the term epileptic encephalopathy. And when we said that the patient had epileptic encephalopathy, where these patients were patients who have frequent epileptiform abnormalities in the EEGs and or frequent seizures, okay? And we thought that this, because they had the seizures and the EEG abnormalities, the development was subsequently affected because of the frequency of these abnormalities and the frequency of the seizures. And part of the definition was, it doesn't matter what is the etiology, okay? And what happened is we ran into a problem when we came with that definition, because if the etiology doesn't matter, okay, we can say we are gonna work hard to eliminate the seizures, we're gonna work hard to eliminate the epileptiform abnormalities, and then this patient is gonna get better and is gonna continue his developmental progress as his peers and siblings within a normal range. But this is not true, okay? So when we used to assess the cognitive function of children who have epilepsy, early onset epilepsy, okay? There is a contributing factor from the spikes and the seizures, okay? There is also a contribution from the anti-seizure medication that we cannot deny, right? Because many of these anti-seizure medications are working in the brain and are slowing down the cognition. Cognitive side effects from the anti-seizure medications are well known and studied over the years, right? So the medication that we are used to solve this problem, seizure and spikes, are also contributing to having cognitive problems. But guess what? The etiology does matter, because we can eliminate in many patients the seizures and spike, yet we will not get an improvement in cognitive dysfunction, okay? So epilepsy and neurological dysfunction doesn't equal epileptic encephalopathy. It does equal developmental epileptic encephalopathy, because no matter what we do, these patients, the underlying etiology prevail, and this patient will not be able to develop as the rest of the normal children. Now, there are exceptions of the rule, right? Because if we follow this paradigm that if we treat the seizures, the patient should get better, that could happen in some patients, okay? And here is an example of the epilepsy surgery outcome at the Cleveland Clinic. This is work by one of my former fellows. And these are, what I'm showing in this graph is a group of patients who have epilepsy surgery, okay? And we use the Impact of Childhood Neurological Disease score, which is a score that is given by the parents. This is parent-reported data of how the behavior, cognition, physical and neurological aspects of life and the epilepsy change before the surgery happened, okay? There were 126 patients. These are the scores before the surgery. And then after the surgery, how the scores change, okay? Higher score means more impairment. Lower scores means improvement, near better. So for the patient who have a lesion in the brain that we were able to solve with epilepsy surgery, the behavior improved over time. At the end of the scale, we have 2 years, right? The epilepsy improved over time, right? The seizure went away, right? The cognition also improved, okay? Although some later on have some worsening on cognition. And the physical and neurological aspects of life also improve over time. So in this group of patients, we were able to take it from the delayed cognitive status that they were and put them in a better place. But this is not true for all the etiologies, okay? So this is how we, this is one of the models that are out there to explain the different pathways of development with children who have epilepsy can follow, okay? So here we have a child who doesn't have epilepsy, okay? So this patient, as he gets older, this is over time, is going to have more, acquire more and more cognition and have a better regulation over the behavior, right? So there are patients who are born with a lesion that will never develop epilepsy, right? So these are going to also, the development is going to progress over time, not at the same level as the children who don't have a brain lesion, right? But there's going to be a progression over time. But what happened is that lesion is epileptogenic, right? So then there is a deviation from that curve because the presence of seizures and spikes will make that development to regress, okay? If we do epilepsy surgery, then we get the cognitive recovery. But what happened is the patient is not a surgical candidate, okay? If surgery is not a choice, okay? Then we are gonna be suffering the consequences of the epileptic encephalopathy, and these patients will continue to plateau or will continue to regress. They won't have, regardless of whether they get to seizure freedom or not. Okay, so that has led to a change, recent change on how we call the epileptic encephalopathies. We stopped calling this group of epilepsies epileptic encephalopathy to name them developmental epileptic encephalopathy and to acknowledge the role on the etiology. So the role of the etiology indicates that there is a similar contribution on the etiology to the generation of seizures and to the generation of developmental impairment. Therefore, by stopping the seizures alone, we are not going to be able to have an improvement in the development score, okay? So you're going to be seeing more and more in the literature that that we are using the term developmental epileptic encephalopathy, okay? So when we are talking about developmental epilepsy, we are talking really about developmental epileptic encephalopathy. Here is the important thing to keep in mind about the developmental epileptic encephalopathies. These patients typically have recurring seizures. The seizures can be of any type. They can have infantile spasms, they can have epileptic spasms, tonic seizure, myoclonic seizure, focal seizures, you name it, any seizure type is possible. These seizures are going to be refractory to anti-seizure medication. They do not respond well to anti-seizure medication. These patients have developmental delay, and many of them have developmental delay even before they have the first seizure. This is a big clue as of to this is going to be a developmental epileptic encephalopathy, likely of genetic cause, okay? The cognitive impairment is variable, but it's present across the board, from mild to severe, okay? Now, many of these patients also have impairments in motor function, Some cannot walk, some cannot talk, some will never be able to sit or run, okay? They have problems with the speech and they have problems with language development. Many of these patients also have failure to thrive or growth abnormalities. So when we are expanding the phenotype and moving from at what age the seizure began, okay, and what seizure types we are having, we are getting a really bigger picture of what the patient has. And why this is important to know, okay. So here, this is, I like this cartoon from the study on Norway, where they look at all the population of patients. They have centralized healthcare, so they can look at the population and really assess what are the problems of this epilepsy who start early in life. So they have multiple brain problems and multiple systemic problems, okay? And what problems are there? The patient have difficulty swallowing, they have autism, they have respiratory distress, and many of them require oxygen. They have auditory processing problems, they have gait abnormalities, they have problems with the fine motor, so some of them cannot even feed themselves, okay? Some of them may have heart problems. The most are typically abnormal as these patients get older, they're gonna have scoliosis. They have intellectual disability, they have problems regulating the temperature, typically hypothermia. They can have endocrine problems, they don't grow well, they have constipation, which is a huge problem, okay? They have behavioral problems, they have seizures, they have problems with the growth, okay? This is the big elephant in the group, okay? So what I want to say now, and I'm gonna repeat it again and again, is the epileptologist is not enough to treat these patients. The epileptologist can aim to improve seizures, but it will not be able to change any of the comorbid problems that this patient has. So these patients need a team. This patient needs a team. So here in this graph bar is a representation again of what these patients have, right? Here we have epilepsy, but as big as epilepsy are the communication problems, okay? And look at the behavioral problems. If they are as bad as the gastrointestinal problems or the lack of motility. Okay, and I think that vision is scoring slow here because vision is not traditionally or systematically assessing these patients. Many of my patients wear glasses because they have visual impairment. Okay, so I mentioned already what are the most common names of genes that we see associated to developmental epileptic encephalopathies. Okay. And I want to show you the results of this study from the NIH that include patients who have atypical Rett, okay, and not typical Rett syndrome, okay. These are the ones who have duplications, etc. Patient who has CDKL5, patient who have FOXG1 mutation, okay, and the patient who have MDD, and they were comparing clinical severities, okay? And you can see the scale, the higher numbers means more impairment for this scale, okay? You can see that these patients who have FOXG1, CDKL5, and Rett syndrome are almost equally impaired in terms of their clinical severity and the needs of these patients, okay? When we look at development, okay, we have toward the left normal development and toward the right more severe in this graph, okay? We again see, look at moderate is the darkest color that we have. The proportion of patients with Rett syndrome that have moderate, severe, or most severe development is significant. Same goes for the other variations of Rett syndrome. Now, if you look at the patient who has CDD, FOXG1, and MDD, we can see that the severe, okay, marked severe, and most severe are the predominant on this population, okay? So the medical needs of these patients are gonna be even higher. Now, with the parents organizations like the Epilepsy Association, who does a great job helping our youth and adults with epilepsy, the parents of these children got organized too, okay? Because these are still rare conditions, right? So when they go to the local epilepsy association or a local epilepsy foundation, they don't find that they have the support that they need. So they have organized themselves into their own support groups. And since I'm very involved with the CDKL5 in particular, I'm gonna tell you the story of what they have done. These are the parents of the children, okay? In 2000, these patients who have CDKL5, they were all lumped together within the negative Rett syndrome. That's what they looked the closest, as I showed you before, okay? So in 2004, they identified it. Let me tell you, the tuberous sclerosis as a disease was identified in the 1800s, okay? I'm gonna compare TSC with what CDKL5 had happened in the last 15, 17 years. So, gene identified in 2004, okay? In 2009, the parents created, the International Foundation for CDKL5 Research. Because the first parent that was diagnosed here at the Cleveland Clinic said, who else has CDKL5? Nobody knew. This is the first family that I found with CDKL5 throughout my clinical practice. So guess what? In 2012, they got the families together once they found some families in the United States and in the UK, and they got the first conference. And they said, we need to learn about this because the doctors don't know anything about this, okay? And in 2013, they partnered with a group in Australia that was studying Rett syndrome and have many patients who were Rett syndrome negative and ended up having CDKL5. And they created the first international CDKL5 disorder database. This is the database that have allowed us today to know what we know about the disease in a very short period of time, okay? Then they said the next step is we need to educate our physicians and create center of excellence. These are places where we are gonna take our children so the physicians learn about them, what are their needs, so we can improve the treatment. And in 2013, they created Colorado and Boston. We came next in 2014, okay? In 2015, they had the first CDKL5 forum because they found that the Lulu Foundation was running parallel to them. It's a family who have a child affected with CDKL5 that have been devoted and have become a great partner to the community, supporting clinical research and animal research to find out how they can fix the genes for children who have CDKL5, okay? And this has continued. By 2019 now, there are 9 centers of excellence in the United States, okay, that provide care because, as I mentioned, CDKL5 is now one of the top developmental epileptic encephalopathies, 7 tops. They even got to the ICD-9 coding people and they said, we need a coding for this disease, okay? We don't want to be coded under Lennox Gastaut anymore because when we code for Lennox Gastaut, we get things for seizures, but we don't get opportunity for management of gastrointestinal problems, motility problems, language development, etc. So there is a dedicated code within the epilepsy designation, used within the neurological diseases, that is the G40.42 dedicated for CDKL5. This is how far this family has gone in short period of time. I have to say for tuberous sclerosis, we are still at the same stage. So in short period of times, the parents have been able to cut up with other well-known diseases are today in terms of how we are really gonna find a cure for the patients. I could have told you the story with SCN1A because the Dravet Foundation have done equally a strong work. The unfortunately problem is that I show you that there are many genes that are indeed rare, and when you don't have the power of numbers, it's very hard to get what these patients need for getting better treatment for the very, very rare, ultra rare disorders. Okay, so how about treatment? Okay, for the, I should have changed the slide to developmental epileptic encephalopathy. We still treat the epilepsies, right? Because the epilepsies are very prevalent. And for that, we have medical treatment. And if there is a lesion, then we have epilepsy surgery, which will give the patient a great opportunity, right? The outcome of this is really expert-based medicine because for these treatments, there is a lack of randomization in the studies. So the best evidence is case series and expert medicine. What is the story of the antiseizure medication for this developmental encephalopathy? So it's the story of lack of efficacy and loss of efficacy. So these parents are going to tell you nothing works, or if something works 3 months later, we don't have anything that works. Okay. The dietary therapies like the ketogenic diet are very popular. And actually, they probably provide the best treatments for many of these epilepsies as of today. In some patients, you can offer a vagus nerve stimulator, or you can do a callosotomy. You can use immunotherapy on some of these patients, particularly those who have West syndrome and infantile spasm. You can do prednisone, ACTH, IVIG. There are some reports. There are new medications like epidiolex, which in my personal opinion hasn't delivered what they promised for this population of patients in particular. Okay. So we are now talking about precision medicine, how to go from treating the electroclinical syndrome to use medications that are better for what we are trapped, the etiology that we are considering, okay? And there have been new medications like everolimus and sirolimus for the treatment of tuberous sclerosis, and some that remain within the investigational area, clinical trials at the clinical trial level, so they don't have names yet. They are still medications known by number, okay? There have been repurposed drugs that were used for something else, and it turns out that they have properties for the particular channel or the particular genetic deficiency that this gene is causing in the body. We have still, some of them are numbers. We have the anakinra or the quinidine for the KCN T epilepsies, ezogabine, retigabine, that was withdrawn from the market and now is back on clinical trials in a randomized and open label fashion, okay? The drugs by the Xenon group, we have memantine, which is used for dementia. Some of these epilepsies, particularly the ones that start early in life and have gain on function on the channel, patients do well with high dose of phenytoin, which is a medication that in general we avoid in children for the chronic use of epilepsy because of how unstable and the autoinduction properties that it has. But some patients do well on high dose of phenytoin. How about the other anti-seizure medication? Well, there are some medications like stiripentol, which are good for a patient with sodium channelopathy, particularly SN1A, the cannabidiol or epidiolex that is out there, and the benefits are more individual related than as a group. So ticlestars have been used for CDKL5. The results were not as exhilarating as the one that have been provided by ganaxolone. We have also had pradiprodil. So it's a mouthful of names that are coming out of the market. And there are medications that are also repurposed that were used in the 80s, like the fenfluramine, and it have turned out to be a terrific anti-myoclonic medication. Fenfluramine was part of fen-phen, a medication for weight loss in the 70s and 80s that came out of the market because of high concerns and have come back as an anti-seizure medication. We have locarcerine and clemizole also that are drugs of being studied. So these are the new arsenal that we have to treat these patients who has some of the genetic disorders that we know today. Now, the next thing is, what is treatment response? Okay, how we are going to evaluate that the treatment, that these new treatments are working, right? So we have, if the patient has seizures, we have the EEG, which is the, along with the seizure, help with the electroclinical syndrome, and then we have the development, right? So for seizure, we don't want no seizures, 0 seizures. We don't want any patient having any spasms. We are typically happy with a reduction of seizure for patients who have Lennox Gastaut, but again, the goal will be to try to eliminate all the seizures. In terms of the EEG, we want resolution of the chaos, whether it is arrhythmia, whether it is a Lennox Gastaut, EEG type with abundant spike and wake complex generalized, no spike and wake, and polyspike generalized. We want that gone, right? And then the development is the part that is typically more difficult to assess, because the developmental tools that we have, the neurodevelopmental tools, are very variable across different age groups, and they have limitations of how much the patient is able to communicate for you to be able to assess it. So it comes out typically to the opinion of the parents and the opinion of the physician, but we need to do better than that. Okay, so it's really the aspect of the treatment that is not easy to evaluate. And now I want to get to the final thoughts. And the first of my final thoughts is, I want to repeat myself. The patient with developmental epileptic encephalopathy need a care team that goes beyond the epileptologist. We need neurologists, we need people to manage the movement disorder that they often have. These patients often have insomnia. They sleep during the day, they are awake at night. We need the sleep specialist. We need the pediatrician, and we need the complex care team, because these patients have silent aspiration, they have pneumonias. We need the gastroenterologist. Constipation, I cannot tell you strong enough how severe the problem is, okay? And in patients who are delayed, these patients start having a normal movement, and come back to the epileptologist. Look what the patient is doing now. It's seizure. You put it on the monitoring unit. No, it's not seizure. What is it? A history of having a stooling every day in these patients while they are on miralax is not good enough to rule out that these patients are not impacted on stool, okay? Because the patients that stool every day have partial evacuation, and constipation is one of the major causes for irritabilities and abnormal movement in these patients, believe me, okay? If there are respiratory issues, we need the pulmonologist in place. Needless to say, the therapies, the equipments are super important, okay? I often have to get fights to get my patients what they need, and it shouldn't be, because the goal of the therapist in these patients may be that they're able to sit or walk, but some of them will not be able to. But then you want to make sure that they don't get spastic and contracted, so the parents won't have limitations to change the diaper, to be able to provide the adequate hygiene that they need, okay? So the therapy needs to remain whether the patient is progressing enough or not, to avoid complications of immobilities. The geneticists is an important part of the group too, because they are the ones who will tell the family what are your risks to have other children with this condition. That's important information that we need to know. We need on board the school system. We need on board the community. We need on board the industry, providing new treatments, and we need the help of the advocacy. So this team for this rare epilepsy is much bigger than the epileptologist per se, and we should be moving in this direction. The second point, that is my one of my take-home points, is about mortality in epilepsy. Okay, so people with epilepsy have a mortality that is 2 to 3 times higher compared to the general population. Okay, this is a particular true for people with epilepsy that have epileptic encephalopathy, those who have intellectual disability, or those who have cerebral palsy. Okay, they are a higher risk. That said, these patients live longer. With the care that we provide today, of providing NG tube for adequate nutrition, of providing NG tube to reducing the aspiration that produce the feeding the patient with by mouth when the patient is not able to swallow, these have resulted in long lives. Okay, it's very common to hear that the patient with Lennox now are getting to the 30s and 40s and even 50s. Okay, so it's true that this patient have increased mortality, but the life expectancy for a patient who have epileptic encephalopathy now gets to the 30s and 50s. We need to provide that these patients continue care. Okay, and one more thing before I move to the next point that I want to mention. In mortality in epilepsy is related to epilepsy, we have accidents, we have deaths. But mortality in epilepsy, particularly in adult epilepsy, is related to lack of preventive care. This group have heard me talk about that before. Patients, young adults who have epilepsy and epileptic encephalopathy, developmental epileptic encephalopathy, they need a primary care physician. Going to the epileptologist alone once a year is not enough, okay? Because these patients are dying from late diagnosed cancer, okay? The preventive care, getting the immunization, getting the vaccination is equally important for these patients. So please advocate for your patients. Make sure your loved ones are getting all the care that they need outside the epilepsy care. This brings me to the transition of care. So what is happening with these patients? They are now young adults, okay? Where many are staying with us, with the pediatric epileptologist or the pediatric neurologist. So for many reasons, we need to educate the adult neurologists, the adult epileptologists on how to care for these patients, okay? We need to have this on board. We need to build the trust necessary to provide the transition of care for this population. We need to have a transition policy in place in our hospitals, okay? We need to start talking about transition of care when the patients are between 13 and 18 years of age, no waiting that they are 18 of age, okay? We need to make sure the family is ready to transition, okay? When the patient is between 14 and 18 years old. And this many times entitled, who is gonna be the legal guardian of this patient? We are talking about patients who have intellectual disabilities, okay? That process, the family should not be started when the patient turns 18, because if the patient has an emergency, who is gonna talk for this patient, right? We need that by the time that the patient gets to 18, all these elements are in place. Who is the next of kin? If the parents are not here, who is the next person? We need to know that by the time they turn 18, okay? We have to coordinate that transition of care with the adult providers. We have to make them not being afraid of these patients, okay? So they can receive the care that they need. And then we should complete the transfer of care between age 18 and 21 years. By then, after that, that should be completed. And we should not have the patient coming back, or like often happen. I didn't like the adult doctor. They know how to talk well with the patients, but here you have to learn to talk to the caregiver of the patient. Okay. The other element that I want to strengthen, and this will be the last element that will be stopping after this slide, is it is important to bring genetic testing to adults with developmental epileptic encephalopathies, okay? Because once we know the gene, we can change the treatment either by selecting an anti-seizure medication or a medication that is more suitable for better seizure outcome in that patient, okay? By reducing the number of medications that are not providing the seizure control that the patient needs, by opening the door for this patient to participate in clinical trials of medication that are now available for this patient with this particular gene problem, okay? And then if we get the patient with seizure reduction and we get them more alert, this is a patient that will be more able to be part of their family and their society, and will be a win-win situation for everybody, okay? So with this, I'm gonna end my call, my talk, and I am ready for any questions.
Thank you so much, Dr. Pestana Knight. Why, we'll give people a minute here just to submit questions in the chat feature if they have any. While folks are doing that, I just thought I do a couple quick announcements, but just thank you everyone for joining today's seminar. I hope you found the information helpful and informative. If you haven't had a chance, definitely take a moment to visit those pharmaceutical rep sites in our virtual marketplace, which was shared in the chat feature. The link was shared there. And as I mentioned before, this is our last seminar series program of 2022. So we conduct these annually. We host 4 each year. I'm sorry, last of 2021. We are conducting these annually, and we are looking to release dates and topics for the 2022 seminar series schedule. So keep an eye out for that. And then we have some upcoming events. Our 30th annual gala is on Friday, November 5th. It's going to be in person at the downtown Cleveland Marriott Hotel. If you're interested in attending, there's more information on our website about that. We'll be honoring 2 physicians from university hospitals. And then we have our annual winter walk that is will be in January of 2022. So we look forward to getting that site launched here shortly. And if everyone wants to save the date, it is January 22nd, 2022. And we'll be at South Park Mall again. And so I don't know, did anyone can unmute if they want to ask Dr. Pestana Knight questions. That way, I don't see any questions in the chat feature, but if you do have a question, you can go ahead and unmute yourself and go ahead and ask away.